A beautiful morning to you. Thank you so much for tuning in this amazing Tuesday morning. I hope you're feeling great today. I hope you're feeling good. Well, it's the end of the year, and of course, it's the Christmas season. So sometimes it just feels as if you have to just feel good. Find a way to feel good. Anyhow, we'll go shall day all right. All right, 7 minutes after 10, right here on Women Radio WFM 91.7. This is Nigeria's first radio station for women and their families. Thank you all so much for tuning in this amazing morning. I hope you've been having a very great time with us, from newspaper review down to panorama, and now we are on the program Radio Doctor. So yes, once again, thank you so much for tuning in and joining us this morning on the program Radio Doctor. Now, Radio Doctor is a free health consultation program where real doctors advise real people. All right, Radio Doctor is Nigeria's first specialized health program where medical doctors consult for free and advise right here on Women Radio WFM 91.7. Radio Doctor comes to you Mondays through Fridays from 10 a.m. Now, today is on women's health, and women's health on Radio Doctor is supported by the ACT Foundation. All right, or you might want to call it ACT Foundation. All right, so that is the foundation that's supporting our Radio Doctor today. All right, so women's health, we get to talk about all that has to do with us. All right, so my name, like I said, is Rose Yusuf Kaiser, and of course, Radio Doctor today, our doctor today is Dr. Collins Abolaje, and he is an assistant medical director and fertility physician at St. Ives Specialist Hospital. Good morning, Dr. Abolaje. How have you been?
Good morning, Rose. I've been okay. Good to be here once again.
Of course. We're excited to have you. Compliment of the season. How is the Christmas doing you? How is it coming up?
Well, the Christmas is not Christmasing at all.
Away. Let us make it Christmas.
But I guess we'll go. So everything is just same old, the usual.
Yeah.
Day-to-day activities, and everybody's just getting by. Yeah.
It's all right. It's all good. It's part of life, yeah. So everything will be okay. All right, so thank you once again for joining us. This is Women Radio WFM 91.7, and of course, this is Nigeria's first radio station for women and their families. And we have Dr. Abolaje with us, and he'll be consulting and advising on uterine factor infertility. All right, so that's what we'll be looking at today. If you're wondering, uterine factor, what is that? Don't worry, something that you're used to hearing, but maybe a different name. But we will definitely get to look at it today. All right, so to be a part of our program today, you can go ahead and dial the number 07000 917 917. Send us a text or a WhatsApp message to 070 317 56537. All right, our social media platforms are there: Facebook, Instagram, X, and of course YouTube at WFM 917. All right, you can also download our mobile app, WFM 917. Log on to our website www.wfm917.com and listen live from any part of the world. So Women's Health today on Radio Doctor is supported by ACT Foundation. All right, we'll just get on to it today with Dr. Abolaje on uterine factor infertility. All right, so Dr. Abolaje, let's head on straight to our conversation for today. Now, when we say uterine factor infertility, let's even understand what is this uterine in a woman's body. What does it entail? Just give us an overview of how that particular part or section of the woman's body works, and how we are at the point of talking about this. The fertility part of it. Just an overview of all of it.
Okay, so basically, as part of the female reproductive system, there is an organ called the uterus, or it is the structure that most people call the womb. Okay, most people that are not medical practitioners, they call it the womb, but of course, as physicians, we call it the uterus. It's a thick-walled muscular organ that is capable of expansion to accommodate a growing baby or a growing fetus. So basically, it is the structure that God has created inside of the woman, where the baby has the ability to, where the embryo has the ability to implant of course, and then grow into the fetus and finally into the full-blown baby. And that is where most of us, in fact, that is where all of us came from. There's nothing like most of us in that situation. So it has a measurement of around 8 centimeters in length, about 5 centimeters in width, and of course between 2.5 to even 4 cm in thickness in some people. So it has some function. The uterus has always been there. Even in a baby has a uterus. Okay, but it's just that it is a secondary organ, so it wouldn't mature until the baby attains puberty. Okay, it will now mature under the influence of the secretion of hormones by the ovaries, which are the primary sex organs. So the uterus now has some parts. Okay, we have the fundal part, we have the body, and of course we have the cervix. The cervix is still a part. I know last week or so, or some weeks ago, I spoke about cervical factor infertility. And that cervix, the cervix now, is also a part of the uterus. Now, there are some histological parts of this uterus or the womb. We have the perimetrum, which is the outer portion of the uterus that is very, very close to the abdominal cavity. And then, of course, we have the myometrum, which is the muscular part. It is that part that stretches, that becomes thicker and bigger and stretches to accommodate that baby that is present inside of the womb. And then we have the inner part. The inner part is called the endometrium. This is the portion where the baby stays and grows until the baby is ready to be delivered. So the inner part has some part, also is divided into some sections. We have the superficial functional layer, and of course we have the basal layer. Don't worry, all these are grammars. Simply means the superficial layer is a portion that sheds during menses, and the basal layer is the one that gives rise to that functional layer. Okay, so for some people, everyone, different women have different uterine positioning, meaning their uterus are positioned differently from each other. For some people, there's something we call anteverted. It simply means the relationship between the uterus and the anterior abdominal wall, or even maybe to the posterior of the pelvic cavity, rather. Okay, so for some people, they have what we call anteverted uterus. For some people, they have what we call retroverted uterus. Okay. All of these are still, these positions will not really affect, it will not prevent the woman from getting pregnant. They are variations of the positions of the uterus, so they are normal. There's nothing like, because I have retroverted uterus, so I cannot get pregnant. No. So basically, retroverted uterus and the anteverted uterus, they are normal variations of the normal position of the uterus. So the function of the uterus, without wasting much time, is that it serves as a site where the baby grows until the baby is ready to be delivered. And of course, it also serves as a site from where the menstruum or the menstrual bleed, from where it comes. It also serves as a passage for the sperm, in a bid to go to in a bid to travel to the tube for fertilization of the woman's eggs. Yeah, I can hear you.
Okay. All right. We just lost you for, I think, a minute or so.
For a little bit.
Yes.
Okay. So now talking about uterine factor infertility simply means infertility that results from the presence or the proper or the improper functioning. Like I made mention of some of the functions of the uterus. So basically, for some people, the reason why they are even having infertility is that they do not even have the uterus. While for other people, is that they have it, but it's just that it is not functioning. Maybe because of one disease condition or because of one acquired condition, that has resulted in the suboptimal functioning of the uterus. And it is also important to note that around 5% of women going through infertility actually have uterine factor infertility. Around 5%. Yes, and some of the causes, just to add that, some of the causes of this uterine factor infertility include what we call something like Mullerian. We call it Mullerian agenesis. Now, this is grammar. It simply means that, of course, the woman does not have uterus. The structures that were supposed to give rise, the embryonic structures that were supposed to give rise to the formation of that uterus, she didn't have it. Okay, so because of that, she won't have the uterus. She might have ovaries, but she won't have uterus. The uterus itself will not be present.
Okay.
Yes, exactly. Which is the womb. The womb itself will not be present. For some other people, they have uterus malformation. There are different malformations of the uterus. For some people, they actually have only one half of the uterus. Yes, only one half. So basically, the uterus is looking like a banana. So we usually say it's like called a banana uterus. Okay, it's just to give people a lot more understanding. So yes, the uterus is like curved, like one half. Just having a banana like this. It's just one of it. That's what the uterus really looks like. And the uterus is supposed to look like a pear-shaped organ. It's like a pear-shaped, pear, avocado pear. So it really looks like that. So, but now for you to be having a uterus that looks like a banana, so basically this is what we call a unicornate uterus. So basically it only has one half of it. For some other persons, they have a uterus that is like two uteruses, okay? 2 uteruses and 2 vaginas. For some other people, they have 2 uteruses and 1 vagina. Yes, for some other persons, they have the normal uterus, but it has a septum in between. We call it a septate uterus. Where there is a septum, it is like dividing the uterus inside, though it's not outside. That division is happening inside. It is divided, it's like demarcated. Yes, that's the word. To be demarcated inside into one half and the other half. But then, of course, looking at the uterus from the outside, it is like the pear shaped. But when you have to look past the camera into it in the form of hysteroscopy, okay, to look at from the inside, then you will see that there's a septum in between. We call it a septate uterus. Most of these genital malformations will result increased risk of spontaneous miscarriages for women. And for most people, it doesn't really prevent them from getting pregnant. Many of these genital malformations will not prevent them from getting pregnant, but of course will definitely increase their risk, even as high as 55% of having spontaneous miscarriages. But some other people could be that they could be having preterm labor. But many of them will not carry their pregnancy to full term because of these malformations. Yes, because the uterus has lost its capacity. Maybe for some reason, by its size, by its volume, has lost that capacity to accommodate the baby to a particular age of gestation. But these are not the only causes of uterine factor. For some other people, they've actually removed their uterus maybe because of having endometrial cancer or uterine cancer. And for some others, maybe because of fibroids and polyps here and there. Or even for women who they got pregnant, they delivered their baby, but they encountered or they had what we call the postpartum hemorrhage, PPH. And usually for that, it simply means the inability of the uterus to actually contract very well to prevent that excessive bleeding, to stop the bleeding after the baby has been delivered. Honestly, the consequence of that for some people can be very, very serious, even up to the extent of having to remove the womb to salvage the life of that woman. So that is one other cause. And now we can go to other acquired causes, which include the presence of immune conditions like adenomyosis, endometriosis, even uterine fibroids, polyps, adhesions. Adhesions also can also be the reason why people would find it difficult to get pregnant. And of course, some other causes where the inside of that womb, like I mentioned earlier, the endometrium of the womb, which is the space where the baby attaches implants and then develops until the baby is ready to be delivered. Usually for some people, that endometrium is very, very thick. It is abnormally thick. We usually call that endometrial hyperplasia. Such things can also prevent a woman from getting pregnant. Okay, because it will also result in other menstrual irregularities and other suspicion. In fact, when a woman has endometrial hyperplasia, usually one of the suspicions that comes to the mind of a physician is that the woman is already at the beginning stage of having endometrial cancer. So usually it's always a serious thing, and we really want to do our due diligence to investigate that woman properly to be sure she doesn't have endometrial cancer. Okay. And then the next thing is that for some people, the endometrium, that inner layer, does not grow to the right thickness. We usually call that endometrial atrophy. So it's not growing to the right thickness. If the endometrium does not grow to the right thickness, the woman might find it very difficult to get pregnant. And lastly, of course, infections, endometritis. Okay, so these are the causes of uterine factor infertility.
All right, Dr. Aboloje, thank you so much for giving us an overview of uterine factor infertility. So basically, we're just saying womb. Yeah, we're looking at factors that could affect, infertility coming from the womb. Yeah, that's just what we're looking at. All right. So thank you. All right, thank you so much, Dr. Boloje. This is 21 minutes after 10, right here on Women Radio WFM 91.7. And this is the program Radio Doctor, your free health consultation program where real doctors advise real people. And of course, today is Women's Health. Yesterday was Children's Health. Today is Women's Health and is supported by ACT Foundation. All right, so let's go ahead. Do well to dial the number 07000 917 917. If you have a text, you have a question you want to ask our doctor today on the topic, please do well to go ahead and call it, even if it has to just do with women's health. All right, do well to call in. The doctor is here to consult for free and give his advice to you. All right, so do well to call in on 07000 917 917. Send us a text or a WhatsApp message to 070 317 56537. And if you want to call in and let us know, or rather you want to tell us how this program has affected you, has improved, your health, your overall health, please do well to call in and let us know. Hello. All right, Mr. Cole, do well to call me back. 07000 917 917. Send us a text or a WhatsApp message on 070 317 56537. We'd love to hear from you this morning. We are looking at uterine factor infertility. All right, so do what to call in. Let's get to hear from you. You have questions, you have concerns, you have, some kind of thoughts that you have in your mind that you would want to know more about, or maybe correct those thoughts. Do well to call us up. We're here for you. All right, Dr. Boloje, so you were talking about, different kinds of, is it different kinds right now? You mentioned introverted, you mentioned, and so on. So all of that. Now,
their positions.
Their positions. And you said that does...
positions.
It has nothing to do with hindering a woman from getting pregnant.
Yeah.
Okay. So now my question is, I saw a video, I think 2 days ago or a couple of days ago, about a lady who was pregnant, but, her stomach was not growing. It wasn't growing. You know how a woman's stomach will protrude now when there's pregnancy?
Protrude, yeah.
Yes. So it keeps going month after month, month after month. After the pregnancy is one of the things they say, they hide. You go see them. But this lady it didn't show at all. In fact, she gave it, all she was just going for scan, and they were telling her that baby was okay. So even to her, she was really, really shocked and surprised. I know this is not really common, because if it were common, we would have seen a lot of women with it, but it's not common. So that's why it caught my attention.
Yes.
So, and then later on, she was explaining that, they said she had, was it an introverted womb or something like that? So the baby was growing inward. I'm not wondering how possible is that? Because it just sounded as if, and that is not a problem at all.
Now, it isn't a problem. I mean, the woman got pregnant. Just that the tummy, the belly wasn't protruding.
Yeah.
I don't think that belly protrusion is actually, yes, I know it is actually an outward sign.
Mm-hmm.
That this woman is pregnant.
Yeah.
Something like that. But it doesn't really affect the baby, so to say. For some people now, the thing is that when they have an antevated uterus, the uterus is facing, it's more like the uterus is climbing over the bladder, tilted anteriorly, tilted towards the anterior abdominal wall, you understand? As for the retroverted, it's facing towards the intestine, towards the back, so to say. So for people, when they get pregnant, whether anteverted or retroverted, anteflex or whatever, as the womb gets bigger, by reason of the growth of the fetus inside of that womb, it straightens out. It becomes straight again. Usually, the womb, now this is the relationship between the womb and every other structure within it, within the pelvic cavity. The womb is in the middle. You have the bladder in front, and then you have the intestine at the back. Okay? So, for some people, there is a small anterior tilt. That is what we call the anteverted now. Where the womb, the head, more like the top portion of the womb, somewhat is bent just above the bladder a little bit. So basically, that is the anteverted. And for the retroverted, it is towards the back. No, now for that lady having that, the tummy was not protruding and all of that because she has retroverted uterus and all of that. So basically, the reason why you won't see it very much is that there's already a space for the womb tilting towards that tilting posteriorly. You understand? And the truth is, in that kind of case, the baby might not be so big. Are you getting me? The baby itself might not be so big. Might not be like a big baby. Because if it's going to be a big baby, the tummy must protrude because the uterus will straighten out. And of course, that bulge will be seen. But if the baby is not so big, for some people, they just have small babies. Their babies are not as, you understand what I mean, robust and all of that.
Yeah.
So basically, that can also contribute to the reason why she didn't have the protrusion. Also, with that retroverted positioning of the uterus. I don't know if I've been able to actually answer some of these questions better. But if I have not, you can always, ask me again or throw more light.
Thank you so much, doctor. I think that actually explains it because I was just wondering, so it's possible because I've actually seen videos like that where you see women actually pregnant, but you don't see anything. In fact, some don't even know that they're pregnant. You don't see anything. There's no sign. There's nothing. Or maybe you just go to the toilet to pee, and then all of a sudden there's contraction and a baby is coming out, and you just you come out with a baby and all of that. So anyway, things happen.
Another thing that can also just to add, another thing that can also conceal a pregnancy like that is obesity. You find some women that are on the very big side, or even have a big tummy. So normally when they get pregnant, you expect that whatever size of the tummy they had before to get bigger than that. But in this case, it won't get bigger because there's already a lot of anterior abdominal fat and all of that. So basically, their tummy would look the same, just look the same way. But then they're actually pregnant. So just to add to that.
Okay. And just to be sure, doctor, you said that there's nothing is wrong. Yeah. It's not like something is causing it from somewhere or, out of all the, the common causes you mentioned. So it has nothing to do with, okay. So it could just be a natural thing.
Nothing to do with. Yes, it could just be a natural thing.
Okay.
So there's nothing really causing it because the truth is the woman is getting pregnant. And just like we rightfully said, now that woman is going to carry that baby to term and she will deliver. It's just that the tummy wasn't protruding. The position of the tummy is not so significant. What is really important is what is happening inside of the baby. Is the baby getting the right nourishment? Does the baby have enough liquor? Is the baby developing very well? These are the things that are the most important thing. Is the uterus, increasing in size and not having any volumetric and limitation, to prevent the baby from reaching term or to result in spontaneous miscarriages. These are the indices, these are the factors, these are the things we want to see, but not about the tummy protrusion. You see some women even, they will be 9 months pregnant, but their tummy came out, but just a little bit.
Yeah,
just a little bit.
True.
Not so much. I've seen a lady like that. She's that slim. She's very slim. And the baby didn't really, in fact, the other day I went to my church now, and I saw the same lady with the baby. And guess what? This baby, she's a girl anyways, and the baby is a little bit chubby. I was wondering, okay, what has been happening? Because your tummy didn't really come out. Your tummy came out, but it didn't really protrude much. So everyone just has
everybody's different
way that they would express, their pregnancy will express itself.
All right, thank you so much, Dr. Abiloji, for explaining all of that. Also, you've told us the common causes of uterine factor infertility. Now, how can all of this be diagnosed? Is there maybe some kind of signs or symptoms, or it's a doctor that has to see that this is what is going on? So how do women come about to find out that, okay, this is what is going on with me, with my womb? So how is this diagnosed? How are all of the,
different causes, how can people know and all of that? So now the thing is, the symptoms that people would experience will be related to the cause of the uterine factor. Now, the thing is that for some people, for some women or young ladies, how they would know, and the way they the thing that they will see or whatever what they will experience to know that they actually have uterine factor is that there will be absence of menses. Imagine a woman who doesn't have uterus but has ovaries. Okay, she would start to experience all as secondary sexual characteristics, breast development, and everything. But of course, she won't see menses. So that will be like a sign for the lady to go over to the hospital, and then she will be checked, scans and all of that will be done for her, and then she'll be found to be to be having no uterus, absence of the uterus. Okay, so that is one sign. Amenorrhea. Okay, it's also a sign. Primary amenorrhea, where the lady has never seen menses. So that is one sign, primary amenorrhea. For other people, they could be having menstrual irregularities, especially for people that will be having things like endometrial hyperplasia and the rest. They will be having menstrual irregularities, maybe seeing infrequent menses. Okay, for other people, they could be having heavy bleedings during menses. These are for people that usually have endometrial hyperplasia. And sometimes for them too, they may even be having absence of menses for a period of time, and then they would see menses again. So it is infrequent, For other people, they'll be finding very difficult to get pregnant. These are for people that, of course, will be experiencing infertility, which is also one of those signs or symptoms that this might be. For others, they could be having bleeding in between menses. Now, what this means is simply that they could see their menses now. Towards the middle of their cycle, okay, they could be bleeding again. But by bleeding this time, it could be spottings. Okay, usually we call that intermenstrual bleed. So basically, you shouldn't be bleeding in the middle of your menstrual cycle. Okay, you should bleed at the beginning. Okay, and then at the beginning of the next one also, but not in between those two menses or in between those two menstrual cycles. I don't know if I'm communicating. So basically, that's called intermenstrual bleed. And one of the causes of this is actually endometrial polyps or even endometrial fibroids. We call that submucous. We call them submucous fibroids. Okay, they could result in spontaneous bleedings or intermenstrual bleeds or spotting for days even after the menses is over. These are some of the symptoms. And then for some other people, they could be having lower abdominal bulginess or lower abdominal heaviness, so to say. For some others, it could be lower abdominal pain. For some people, they could be having pain during menses. And they will be having pain during menses, having all the cramps. And then, of course, they are still not seeing the menses, but the cramps is right there, disturbing the lady, preventing her, affecting her quality of life every time she gets that time of the month when she's supposed to see her menses. But she wouldn't even see menses. For such people, they might be having uterine adhesions, okay, that has prevented the flow, okay, from coming out. So the flow will be present inside of that endometrial cavity, but it is not flowing because there's adhesion in the outlets, preventing the menstrual bleed from flowing out. So usually they will have what we call cyclical pain. Cyclical pain is also one of those symptoms. And for others, they could be having, everything might just seem okay, but they are having recurrent miscarriages. Or they are having uterine adhesions. Okay, so that could just be the reason they're having recurrent miscarriages. I'm pretty sure in the coming weeks, we'll look for a time to discuss recurrent miscarriages so that we'll throw more light on this and people will get proper understanding as to why it has been happening. So, like I said earlier, the symptoms will be related to the underlying cause, be it fibroid, polyps, adhesions, presence or absence of the uterus, having uterine malformations and all of that. Then, like I said earlier, for people that usually have these uterine malformations, 2 uterus is half of the uterus, or having a septum, they usually predispose them to having miscarriages or having preterm labor or preterm contractions. And of course, intrauterine fetal growth retardation, the baby will be smaller than expected because the womb does not have that capacity for the womb to grow, for the baby to grow very well. So because of that, it can also result in a retardation of the growth. There will be restriction of the baby, the growth of the baby.
Okay. This
so
is definitely interesting. Thank you so much, Dr. Aboloje. This is Women Radio WFM 91.7, 25 minutes to 11 right here on Radio Doctor, your free health consultation program where real doctors advise real people. All right, today we have Dr. Colin Aboloje. He's an assistant medical director and fertility physician at St. Ives Specialist Hospital. All right, my name is Rose Yusuf Kaiser, and of course we are looking at uterine factor infertility today. So do well to call in via the number 07000 917 917. Send us a text or a WhatsApp message 070 56537. We'd love to hear from you this morning. We'd love to hear your concerns, your questions, and anything you have in mind as regards to uterine factor infertility this morning on Radio Doctor. Now, Women's Health is supported by the ACT Foundation. All right, so do you want to call us up? Let's get to hear from you. All right, so now, Dr. Collins, so we've talked about how this can be diagnosed. Are they readily available treatments for all of this? Issues that might come up with the womb, or with our uterus as women. Are there treatments that are readily available? Are there things or are there drugs or, and so on that we can just take and correct all of these things and just move on to have, babies when we want to and all of that? Or it has to take a long process, or there's actually a time frame to all of this? Let us know, please.
All of it. Okay, now I think I omitted something the last time.
Okay.
Before I jump over to this question that was asked, I was talking about the diagnosis. In fact, it was the moment you mentioned diagnosis, I just remembered that, I skipped that part.
Okay.
Talking about the diagnosis generally. Some of the ways to diagnose uterine problems, or uterine factor infertility include the use of imaging modalities like the HSG, hysterosalpingography, which says that it's usually done to check the tubes, but actually it can also throw light on the womb itself and show you if there's any pathology or if there's anything wrong with the womb itself, to an extent anyways. And of course, I'm used to diagnose problems like fibroids and all of that. The scan can also help to show us if there are presence of fibroids, polyps, adhesions, endometrial hyperplasia, or even endometrial atrophy. And of course, MRI, sonohysterography, hysteroscopy, which is the one I spoke about, passing the camera into the womb to actually see directly, have direct visual observation, assessment of the endometrial cavity. And of course, laparoscopy for some cases for people even having endometriosis and the rest. And then, of course, endometrial biopsy for people that also have endometrial hyperplasia. Okay, so these are some of these diagnostic modalities. For treatment, treatments will start from the use of antibiotics for people that have endometrial infection or what we call endometritis. And then for other people, we will talk about hormone replacement, especially for people that have thin endometrium, endometrial atrophy. Usually we will see people that have thin endometrium. They are usually people that have attained menopause. Or we call them postmenopausal women. They've attained menopause. So basically, there's no estrogen production that will stimulate the growth of their endometrium anymore. So you have to give it from the outside, especially when they want to do IVF. So for women who attain menopause and they are still desirous of having a child, even to attain menopause. So they will come in for IVF, of course, where we will have to do hormone replacement therapy for them. All of that. And then for other people, there could be surgical interventions also. But surgical intervention is not for everything. It's only for people that have fibroid, polyps, some persons that have some congenital uterine malformations that can be corrected, especially like the septate uterus. The one I said has a demarcation inside of it, even though on the outside it looks fine, but on the such uterine malformations, of course, it can be surgery to correct all of that. And for others,
all right, Dr. Collins, let me just hold you. Just hold on a bit. Let's try this call. Hello, good morning. Hello, are you there? All right, I think network is playing a prank on us this morning. Do want to call us back on 07000 917 917. Send us a text or a WhatsApp message to 070 317 56537. Do want to call in, send us a text if you can't get to us through the phone lines. We are definitely here to hear from you this morning. All right, Dr. Collins, go ahead. You were talking about the treatments available for this.
The treatment. So for some other persons, they would have to do what we call adhesiolysis, which is the breaking of adhesions. Adhesions are primary cause of, they're usually culprits for people having recurrent miscarriages or having scanty menses or even having infertility. Like I said, they are still culprits. So adhesions are scarifications of the womb. Usually could be.
All right, just a moment, Dr. Collins. Just a moment. Hello, good morning.
Good morning, ma'am.
Good morning. How are you today?
Good morning, I belong Dr. Brea. I'm listening to the program, sir.
Okay. What's your name?
I'm Joseph. Sorry, I'm calling from Ogba.
All right, Joseph. All right, Joseph.
Yeah. I have this my daughter. She's been losing pregnancy. And then at one time, she carried the pregnancy for about 7 months. So we took her to the teaching hospital in Benin. the monitor on bed rest and all that. And finally, again, suddenly we are called in Lagos that this baby is going and all that. And everything was done. She still loves that baby. Then yesterday, the 2 days ago, I just spoke to her. I said, how are you recovering from that issue? Because that was about 4 or 5 months ago. She said, please, I just lost another pregnancy. She's tired. So I was feeling very frustrated. So when I stopped on this year's program this morning, I was very excited. So let me listen and follow. So we are just, everything we are just saying, she was losing. She lost another one. She said this time around, they said, don't go to the medical people. They have tied the stomach. You still lose the baby. They went to do traditional tying. She still lost the baby and all that. I said, look, don't worry. I will make some inquiries. And I had this program. I said, look, I just have to call. Because I was thinking of even getting her to, she said, bringing her to Lagos. But since I had this program, I was just excited to say, God, this is your own doing. I need to call to her. I don't, she's really frustrated. The husband is my son.
Okay.
The husband is tired. They are just tired. They are just, I don't know. I don't know. So I'm just excited to share this program. So I need more counseling. I don't know.
All right,
Thank
Mr.
you.
Joseph, can you send me a text or a WhatsApp message after this?
Okay, I will do that.
All right. Wait, okay, you said you're calling me from Ogba.
Yeah, from Ogba here in Lagos.
All right, so just send me a text after this and we'll see how we can go about it with that. Okay, just in case the doctor does not, maybe mention a lot or because of our time. So maybe we can...
I understand. Yeah, I understand. Thank you very much.
Thank you.
God bless.
All right, thank you. God bless you too. Thank you. All right.
Okay. So, Mr. Joseph, Yes, Mr. Joseph, so I heard you. So basically what your daughter is having, she's having what we call recurrent miscarriages. And usually there are a lot of causes of recurrent miscarriages. One of them could be problems, especially depending on the time at which that miscarriage happens. For some people, it's usually limited to just the first trimester, which is the first 13 weeks of the pregnancy. For some women, you see them having recurrent miscarriages at 8 weeks, or 12 weeks, 12 weeks, or even 6 weeks. Usually for those type of cases, they are usually attributed to problems with the embryo. Meaning the early, the embryo is the product of the union of the sperm and the egg of the woman. Usually when a bad quality sperm or a bad quality egg gets fertilized by either a good quality, basically if there's a compromise in the quality of either the egg or the sperm, it will result in a compromised quality of embryo. And that in itself can result in spontaneous miscarriages. Yeah, can result in spontaneous first trimester miscarriages. You understand? But from what you just said, now your daughter is 7, the lady in question is 7 months, pregnant, and then she still went ahead to lose the baby, even though a cervical sacrilege was done. Now, from what I see there, okay, with that, having losing a pregnancy of 7 months usually already speaks about the woman already having problems with most likely the cervix. There could be weakening of the cervix. So because of that, or we'll call that cervical incompetence. So because of that, it will result in miscarriages in women in their second trimester or towards even the third trimester. Okay, so in this case now, that lady has to visit the hospital. A lot of investigation will be done for her because the cause of recurrent miscarriages are a lot. It's not just embryo quality or sperm or egg quality or cervical incompetence. For some people, they could have systemic diseases that can result in miscarriages. For some women, even diabetes can result in miscarriages. They could have a condition like an autoimmune condition where the body's like producing substances that fight the body. You understand? We call it antiphospholipid syndrome. Okay? Or for some other people, they could be having a condition called thrombophilia. There are a lot of them that that lady would have to be investigated for. Okay? But overall, if the miscarriage is becoming incessant, is becoming recurrent, and every time, whether 8 weeks, 6 weeks, now in this case almost 24 or 28 weeks, she's having miscarriages, then of course that woman should be very, very quick and proactive about her next step, and would most likely have to start thinking about surrogacy. Okay, because the next question I was actually going to ask is about the age of the woman. Because if she's now tilting towards the time where, of course, she's already having a reduced amount of eggs and all of that, that in itself too can still result in spontaneous miscarriages. Okay, like I made mention earlier of egg quality problems. Okay, this can also result in miscarriages. But since she still has the ability to produce eggs and all of that, and she's still getting pregnant, for some people, their solution, will be to use a surrogate where they would have to do IVF. Okay, but this time they would have to subscribe to the services of a gestational carrier. Somebody will carry the pregnancy. The egg and the sperm of the couple will be used, but the embryo will be transferred into a surrogate to carry that pregnancy. It's usually the last resort when it comes to recurrent miscarriages. And usually works, usually helps them.
Okay. All right. Thank you so much, Dr. Bolaji, for taking time to explain some of these factors that might just be affecting his daughter. All right. So this is Women Radio WFM 91.7. Do well to call us up on 07000 917 917. Send us a text or a WhatsApp message to 070 317 56537. Let's get to hear from you this morning. I hope that, Mr. Joseph, to an extent, you have heard some of the things that our doctor said. Hello, good morning.
Hello, good morning.
Hi, good morning. What's your way you calling from?
My name is
Chidimma. All right. Where are you calling us from, Chidimma? Idimma.
Yes.
All right. Where are you calling us from?
I'm calling from Lagos. I just want to ask you a question. I don't know if it's related to today's phone,
All right.
but it's related to women and pregnancy.
Okay.
So if a woman has ICS, like irritable syndrome, and she's put on loperamide for a while, like it's a lifestyle drug because of the irritable syndrome, is it okay for her to take it even while she's pregnant?
All right, just hold on. Dr. Collins, did you hear her? Because I'm finding it quite...
No, I didn't hear her. She said the woman has what?
Okay. Can you just go over that again?
Irritable bowel syndrome.
Irritable bowel syndrome.
Irritable bowel syndrome. Okay.
Okay. And find it hard to hold.
No, and she takes loperamide normally. Is it okay if she keeps taking it even after she's pregnant?
Okay. So she's taking...
Basically, the question is, can a pregnant woman keep taking loperamide as a routine drug for diarrhea due to irritable bowel syndrome?
Oh, okay. All right, Dr. Collins.
Okay. Yes, so now this is what I can say. You know, some of these drugs, they are differentiated into certain classes, and some of them are not allowed during pregnancy because they have the ability to result in fetal, problems, to cause problems for the baby, especially when the woman is pregnant. So usually, because she has that condition, irritable bowel syndrome, she should have been seen by a gastroenterologist, which is the people that attend to people having intestinal problems, and all of that. So basically, the medication it would give to her to control the diarrhea and all of that would be one that is allowed for women that are pregnant. So now I'm going to return that question back to her because I cannot really give as to that drug. I know that drug is actually Lomotil. Yes, it's actually Lomotil and all of that, or the one we call Imodium. So basically, I would have to look up on that drug. Usually for physicians, when a woman is having diarrhea and all of that, we are not so quick to start to give medication. We will have to first of all start with using food remedies, eating bread, or I'm just giving just an expo that we do because we are always very, very careful about these medications. And the thing with pregnancy, it comes with so much of hypermetabolism, it's a hypermetabolic state. For some people, even besides having any underlying condition, they could be having constipation or diarrhea for some people. So you want to use other known available remedy in the house to try to solve that problem that she's having with constipation or even with diarrhea now, as is in this case. So for that particular medication, I think she should see a gastroenterologist and who would be able to profile a better medication if he deems it fit, if he sees that particular medication is not allowed in pregnancy. So I wouldn't want to give any other recommendation anyways to that, but that is going to be my best advice. Let us see a gastroenterologist, the person that diagnosed her with the irritable bowel syndrome, and of course explain to her and let him know that she's now pregnant, so that medication will be reviewed and a better tolerable one, or the one that doesn't have any fetal toxicity or embryonic or fetal adverse effects, or side effects that will be used.
Okay. All right. Thank you so much, Dr. Collins, for that. Now, we have a question here, and it says, hello, doctor. Please, after surgery for endometriosis, I'm experiencing upper belly bulge, and I was told it is ascites. I hope I got that right. Please advise.
Yes, she's experiencing ascites.
Yes, ascites. So she was told it was ascites. So, but she's experiencing upper belly bulge, and she was told it was ascites, and she's asking for advice. So that's after the surgery for endometriosis.
But okay, I think what the information she failed to give to us is how soon after the surgery did she start experiencing the ascites? Now, the thing with most of these abdominal surgeries or with endometriosis, the problem is with endometriosis that there is deposition, there is the presence of that endometrium. I made mention of it earlier.
Yeah.
It is found outside of the womb. The endometrium, that endometrial tissue rather, shouldn't be found elsewhere in the body. It should only be found on the inner part of the uterus of the womb. For some people, they have the presence of these endometrial glands and tissues outside in the ligaments that are behind, the ligaments that are holding the womb to be at the center between the bowel and the bladder. They are present on those ligaments. They are present on the abdominal wall. For some people, they are even present on the navel. So for this woman now, maybe I don't want to have to say that maybe there could have been complication of the after the surgery or in the surgery or with the surgery as maybe. It could also be most likely maybe something has been tampered with. I don't want to have to say that, but it is also possible. And it can also still be that there is now the presence of that endometrial tissue in a location that will result in this abdominal bulging that the lady is experiencing. They are saying that she's having ascites. It could be possible that maybe the lady had what we call an endometrioma. Okay, an endometrioma is when there is presence of this endometrial tissue on the ovary. It results in the formation of a cyst. We call it a chocolate cyst, present on the ovaries. So after surgeries now, you could still find some seeping into the pouch of Douglas. Okay, and this can also result in the abdominal bulge that the lady will be experiencing. Well, I expect that it should improve over a period of time. But if it is not improving, then she should visit the hospital so that she will be checked. But of course, abdominal bloating is not uncommon after some abdominal surgeries, especially with one that has to do with cyst removal and all of that. Even for people that have cysts, for some of them, they could still have a complex cyst formation even after removal of the cyst. But usually it should resolve. It should resolve over time as the healing process takes place. But with endometriosis, it can really be very challenging. You will find out that you go in for one surgery to remove endometriotic lesion from one particular area, and then you find another one within the next couple of months or within a year somewhere else in a site that you never even knew it would exist, and then start causing problems. So she would need proper evaluation again, all the hysteroscopy, laparoscopy, and all of that to be sure that nothing has been tampered with, and just to give her the best care.
Okay, all right.
It's not something that a solution can be given to her right here, right now. So she has to be reevaluated again this time, even with laparoscopy, to be sure that nothing has been tampered with. There's no other further spread of that endometriotic process.
All right. Thank you so much, Dr. Collins. Our time is fast spent. So in less than a minute, what do you want us to take home from this uterine factor infertility? Because we've not even been able to cover all of what we need to cover today, although we touched a lot of it in your overview earlier. But what would you want us to take home today? Your final words on this.
So basically what I would like to say is that when it comes to infertility or any gynecological complaints or gynecological condition, it would require proper evaluation. Okay, and of course prompt evaluation is also on the part of the person, on the part of the patient now, is also advised, so that they go back to the hospital on time, so that whatever can be salvaged from the condition or the proper treatment can be given to them on time, can be treated on time. Emphasis with prompt and on time. Okay, so because with conditions like this, the earlier the better. With conditions, some of these conditions, the earlier an intervention is instituted, the better for the client, maybe to actually give her the lasting solution that she deserves. So this is what I would say. This is what I would like to add to that, to say as a final word.
Okay. All right. Thank you so much, Dr. Collins, for being a part of our program today.
Thank you, Rose, for having me once again. It's always a pleasure to be here to discuss and bring information to people.
All right. Thank you. Do have a great day and enjoy the Christmas week ahead.
All right. I wish you the same.
All right. Thank you. Bye. So that's our radio doctor for today, Dr. Bolaji Collins. He is an assistant medical director and fertility physician at St. Ives Specialist Hospital. Thank you for tuning in and listening to Radio Doctor Today, which is Nigeria's first free consultation specialized health program right here on Women Radio. And Women's Health on Radio Doctor Today is supported by ACT Foundation. Thank you to the producer of the program, Esther Laribe, and the executive producer, Tomo Kewale Shunai. My name is Rose Yusuf Kaiser. Just stay tuned to Women Radio, WFM 91.7. Good morning.
WFM 91.7.